Good afternoon, Madam Speaker, Mr. Vice Speaker, counselors, alternate counselors, members of the Board of Chancellors, friends, guests, colleagues. This is one of the best times of the year for me. It's my chance to tell you very briefly what's happening at the college. As you all know, there is so much complexity to the college. I can't possibly explain to you everything that's going on, but I would like to highlight just a few things that have happened since the meeting last year. One of the most important changes is we've had a transition in the leadership of the college in the position of Chief Executive Officer. I'm delighted today that both our former CEO and our current CEO are in the room. You can see on the left a photograph of Dr. Harvey Nieman. Harvey was a member of our Board of Chancellors. He ran the Commission on Ultrasound and Economics, then rose to the position of Vice Chair and Chair of the Board of Chancellors, and then became our CEO about a dozen years ago. If any of you don't know Harvey Nieman, it's amazing because he is one of the most outstanding and well-known radiologists in the world. He has been a mentor to me and other members of the board, an advisor, and an inspiration. He has changed the face of radiology and the care that we give to our patients. It was Harvey who had the vision to put the resources in place to create the Government Relations Division and Commission and the Economics Commission that we have today. It was Harvey Nieman who, in large part, with others, had the vision to create the Journal of the American College of Radiology, the Education Center, the Radiology Leadership Institute, and many more. It's now also a pleasure to let you know that the search committee has selected Dr. Bill Thorwarth to be our next CEO, and he took office about 2 weeks ago. I think you may have read my article about Dr. Thorwarth and other articles in the bulletin or seen other publications. Dr. Thorwarth comes from a background of, again, outstanding contributions to radiology. Dr. Thorwarth was a former member of our Board of Chancellors and chairman of the Commission on Economics. He's a past president of the college and a gold medalist. He has also served with distinction on the board of the Radiology Society of North America and has contributed greatly to the AMA and the CPT editorial panel, among other things. I want to stop for just a moment to go back to Dr. Nieman because we've prepared a short video as a tribute.
Approximately 11 years ago, I was offered the position of Executive Director, Chief Executive Officer of the ACR. This was certainly one of the most significant changes that one can make. To take the job meant giving up the practice of medicine. It meant changing cities, selling the house where our children were born and grew up. That step, however, has proven to be extremely positive, a wonderful result of emerging changes. Being the CEO of the ACR has been a wonderful experience that has had significant influence on both the ACR and me.
The successes that we have seen, such as the NIPA legislation, are because of you, the volunteer leadership, who give so much of your time and effort to the college.
I want to take this time to thank staff in Reston, in Philadelphia, in Silver Spring, and in DC, who have worked so hard and have been so instrumental in making ideas for change come true. The Education Center, the American Institute for Radiologic Pathology, the JACR, the Radiology Leadership Institute, the Health Policy Institute, and the expansion of our government relations and advocacy programs. Without excellent staff, my vision for change would not have been possible. We have a truly outstanding staff who work closely with our volunteers. Together, they have built the college into one of the most forceful and successful specialty societies in D.C.
Rest assured, the ACR will remain strong and prepared to deal with the issues our specialty faces and continue to achieve victories.
Thank you again to both Harvey and to Ellie, and thank you to the staff for creating this tribute. In a moment, I will ask Dr. Thorworth to come up and give the report of the CEO, but first I wanted to show you that even before he assumed his duties, we put him to work, and here he is doing his first unofficial chore as the CEO. It's been a breakthrough year. Good things have happened to the college over several years. This year in particular, I think, was very satisfying. I want to just briefly touch some of the things that have happened again since 1 year ago. We had a very successful 10th year anniversary for the JACR. Dr. Hillman, who is still the editor-in-chief, tells us that we have a new look coming both inside and outside beginning this year, so look for that soon. Imaging 3.0, which we introduced to the council a year ago, has now gained wide acceptance. Dr. Bibb Allen and other members of the Commission on Economics have put this together and have implemented this and taken this to the chapters and other societies around the country. And we believe that this will be a new paradigm for the concept of how radiology will and should be practiced, at least for the next decade. We had a very successful meeting last year following the council in this building of the Global Summit for Radiology Quality and Safety, an international meeting focused on quality and safety. We will repeat this again on an every other year basis, alternating between Europe and the United States, and the next meeting is scheduled in Barcelona in October of next year. Most of you know that the U.S. Preventative Service Task Force has now given a grade of B to lung cancer screening. This was based on work done by Akron in 2004 that showed the benefits and the lives saved with lung cancer screening. There is a limitation at the moment. It's for men between the age of 55 and 80 who have a 30-year history of smoking. This is now, because of its grade by the U.S. Preventative Task Force, and by the way, a grade of B is a good grade. What this means is that private insurance companies are now mandated to pay for those screening tests, but, especially when those people are in the exchanges created by the Affordable Care Act. We are in consultation with Medicare, hoping that they will adopt the same policies and reimburse for that as well. Last year we had the task force report on teleradiology, which has been published in the journal, and we are in the midst of working with the new task force on interventional radiology and interventional neuroradiology, and they will be reporting to you both in person and in the journal in the near future. This was also the year of the 5th edition of BI-RADS. This goes back 15 years. Those of you who are radiologists in the audience will recognize that BI-RADS has become widely accepted by not only radiologists but other medical specialties. It's the area that we have been most successful in terms of a lexicon, and we are now very proud that the 5th edition includes not only mammography but also ultrasound and breast MRI. And we are expanding this concept of a lexicon into other areas, including but not limited to MRI, prostate, lung, liver, thyroid gland, and there's just beginnings of efforts in the area of gynecological ultrasound. Congress enacted the SGR patch with multiple imaging provisions, and in addition, our Commission on Diversity and Women, actually it's a commission for women and diversity, has published or submitted 2 articles to JACR, which you'll be seeing. I've had the privilege of seeing these in draft form, and you will find these articles both very informative and compelling and inspirational, and I hope you enjoy them as much as I have. Of these breakthroughs that occurred this year, it's the congressional approval of the imaging provisions that I believe will be game-changing, and I want to highlight this for just a moment. Just to briefly let you understand, in case you have not been paying attention, decision support is now the law of the land. The legislation was passed by the House first, H.R. 4302, by a voice vote on March 27th. This was ratified by the Senate on 3/31/14 and signed by the President into law on 4/1/14. This legislation is effective in January of 2017. At that point, for high advanced imaging, including CT, MRI, and PET, it will be required that decision support be applied. As you know, the college has for over 15 years worked on appropriateness criteria. These have now been transformed into a digital web-based manifestation that can be embedded in the electronic health record, and this is now available and is being used in many places throughout the United States. This ties in perfectly with the Imaging 3.0 initiative because the intent of this legislation is to perform all of the imaging that is necessary and beneficial and none that is not. This also results in a limitation in radiation dose. It eliminates unnecessary repeat procedures and helps to avoid ordering the wrong test. The appropriateness criteria were started by Dr. Max Cloud, who was chairman of the board at that time, 1993 actually. He testified before Congress and said that the college could create these appropriateness criteria. Panels were set up, and we've had many dedicated people working on this. This slide just briefly shows you the number of panels and procedures that we have included. Just to highlight a few things about the entity, it's now called ACR Select, and this is still available online to any of you who'd like to look at it. It is licensed to the electronic health record companies, the ones that do computer physician order entry, and includes Epic, Cerner, and others. Currently, there are 30 facilities in the United States in 17 states that are using decision support. We know from a 10-year period of activity at the Massachusetts General Hospital that this is effective. It does result in appropriate utilization. And in addition, we have now been speaking with our friends and colleagues from the European Society of Radiology and have signed a memorandum of understanding. We expect to go forward and create a European edition of the ACR appropriateness criteria, and it'll be called ESR iGuide. Just to briefly tell you about the legislation, what the AMA and almost all specialty societies were hoping that we would get an SGR fix this year called the Doc Fix. This is in response to legislation from 1997 that has resulted in calculation each year that has been imposed on Medicare spending, and over a period of this time, a deficit of about $300 billion was calculated by the CBO. Recently, they came up to new numbers because of decline in healthcare procedures and imaging and pharmaceuticals, and they felt that this year they could solve this problem with a Doc Fix, a one-time fix. An unusual thing happened. We actually had bipartisan agreement. The House has two areas of jurisdiction. The House has the Energy and Commerce and the Ways and Means, and in the Senate there's the Finance Committee. All three of these bodies agreed this year to do a Doc Fix, and we thought that we could endorse this legislation and at the same time try to add on to this legislation some provisions that would be helpful to radiology. Well, the problem was that they had to have a pay-for to create the money to save to pay for the fix. And there were many suggestions, but none of them worked. The first idea was to delay the implementation of the individual mandate in Obamacare. This was not acceptable to the Democrats. The other was to save money from winding down the war in Iraq and Afghanistan, and the Republicans felt that this was an accounting technique that didn't really save money. And as a result, the SGR legislation did not pass. So once again, a patch occurred, a one-year patch, and we were successful in having the provisions that are important to the ACR included. This is unprecedented, and it is really a game changer. It will affect all of our patients, our referring physicians, and our radiologists beginning in 2017, if not sooner. Just to highlight two of those provisions, one says it promotes evidence-based practices. The Department of Health and Human Services will be required to use appropriateness criteria among those developed and endorsed by national professional medical societies such as the American College of Radiology. The other thing that's very important to us, many of you in the audience know that the multiple procedure payment reduction legislation has been a significant negative in our view. We don't think it's justified, and CMS has been unwilling to release the data. This legislation now forces transparency and requires the Secretary of Health to release that information. We believe once that has been open to the public, we will be able to analyze that information, and if our suspicions are correct, we'll be able to go back to Congress and to CMS and ask them for a correction in the MPPR. This you probably can't read. These are actually 5 areas that were in the legislation that passed. And just to give you a quick overview of some of the others, there's a dampening clause that says CMS cannot change any payment for procedures that has an effect of more than 20%. In the past, they could overnight decrease a procedure for as much as 50%. Now they have to have a 2-year warning so that we can plan if there is going to be a reduction in reimbursement. The legislation also talks about radiation dose safety, and this will have an impact on the types of scanners that we use, particularly in CT, and we think that will be a positive. And finally, this legislation also will be a benefit, I believe, to all physicians, and I know the AMA supports this as well, and that's a delay in the implementation of ICD-9 for 1 more year. So this is a tremendous victory for the college, a testament to the success and astuteness of our government relations and economics department. And again, in my opinion, this will be looked back at as a seminal event in the history of radiology. The product that we are selling with another company that's actually rolling this out for us is called ACR Select, and it's the National Decision Support company that we have partnered with. I mentioned that there are other people that are looking at this, and we have several guests with us today from the European community, including Dr. Luis Donoso from Barcelona, and his hospital is in the process of demonstrating this to the physicians of Spain. We believe that that demo has been successful, and we hope that a product similar to ours will be widespread in Europe as well. I think things are definitely looking up. But as you all know, occasionally there are unexpected consequences. Here is an example. You have to look at the, radiologists, you have to look at the entire film. You know that from the boards. So there's another area that I have received a great deal of email on. The Joint Commission has proposed some changes in the rules. And many emails said, well, what is the college going to do about this? Are we going to respond? I don't intend for you to read this slide. This is merely to show you that the college has given a great deal of thought to this and has prepared a response. We submitted that in a timely fashion, and that remains to be seen how that will finally play out. As already highlighted by the speaker, we're really excited that the AMCLC will be moving up the road about a half a mile to the Marriott Wardman next May. We're calling this the Crossroads of Radiology at ACR 2015. The program I have seen, it's going to be spectacular. Everything that you remember from the AMCLC, such as we're in right now, will be available at the new meeting, but we'll be adding considerable content that will bring you highlights from the RLI, the AIRP, from the Nieman Policy Institute, from the Education Center, from several of our subspecialty societies. And so you'll be having a choice of as many as 5 or 6 different options that will be available simultaneously. There will be an opportunity for CME and for small vendor support. We're hoping to have as many as 3,000 attendees next year. We're hoping that the resident fellow section will be as large as 500 or 600 people. And we think that this will also be a game changer going forward to get our message back to the larger radiology community. We're calling a meeting for all members. We don't expect 36,000 people to attend. That would be actually somewhat of a nightmare. But we do hope that this will really give a broader exposure to the things that the college does. I just wanted to make just a few more comments. I wrote an article in the JCR a few months ago. I am a perpetual optimist. I indicated that I am one that believes that the glass is half full rather than half empty. I explained my thoughts in that article. I don't think it's necessary for you to go back and dig it out, but I actually have had a little bit more information since that time. And I now know that the glass is not actually half full. What I have learned is the glass is completely full. Just happens to be 50% air and 50% water. So we can still learn even at my advanced age. I want to take just a second to thank everyone. This is the last opportunity that I'll have to address you as the chairman of the board. I really think that our Board of Chancellors has done a spectacular job. I have been so honored to work with them. The steering committee has been wonderful, and the speaker and vice speaker, who are members of both the board and the steering committee, have been outstanding. I don't have time to recognize the ACR staff individually, but we have 400 people that work at the college, and they are tremendous. We have over 1,500 volunteer physicians and physicists that work on 250 commissions, committees, and task forces. The council and the members of this organization are all spectacular. Of course, I want to thank you for your attention and the support that you've given me. I certainly need to recognize my wife, Mackie, who's in the audience, for her guidance and support. And I hope you have a wonderful meeting. Thank you very much.